to give you an overview of what the course will hold. So as I mentioned, Dr. David Herndon, his legacy was long when he was here at Shriners Hospitals for Children in Galveston. And he started in the 1980s and retired about a couple of years ago, and actually helped train Dr. Wolf when he was just a fellow. So that was a few years ago. But his legacy is long-lasting in the world of burn care, not just here in Galveston, all throughout the world. And it really all comes down to this philosophy. Our hope for the future is that through multidisciplinary collaboration, scientists and clinicians will pursue solutions to the perplexing problem that burn survivors must encounter. The scope of burn treatment extends beyond the preservation of life and function. The ultimate goal is the return of burn survivors as full participants back into their communities. So it's not just enough to get this patient out of here alive, right? Like, we want to see them not only be able to walk and talk again, but we want them to thrive, even after traumatic burn injury. And how we do that is that communication piece that Dr. Wolf was talking about, right? Like, every component must come together for this patient to maximize their outcomes. It's also, not just the nursing and physician side. It's child life, helping with things like going out in public for the first time. It's psychology, who can do role play. How do you deal with stares? How do you deal with bullying? Or our school reentry program, where we'll actually go and talk to administrators and students about little Johnny, who suffered a burn injury, but actually he's not any different than he was before. He may look a little different, but he's still your friend. He still likes baseball. So it's important that we remember it's not a diagnosis-driven thing, right? Like, we don't just treat the burn injury. We treat the patient with a burn injury. And so it's so important that we remember it's not just the wound that comes with it, but the person behind it. And we want them to come back to their communities as fully functioning members. And as Dr. Wolf mentioned, no scars, no pain, no death. And I really appreciate this forward-thinking mentality, because we should always strive for these. And honestly, I think it can happen. Maybe not in our lifetimes, but if we continue working towards these things. No scars. Well, right now, we've been able to eliminate a lot of this hypertrophic scarring through the use of pressure garments and silicone inserts and things like laser therapy, where 20 years ago, this would be something that would be hard to look at and very rough. But now we can go in, we can smooth the surface of the skin, we can reduce discoloration, so that people, even with massive burn injuries, have much less scarring than they did before, which is absolutely incredible. And if we continue on that trend, we might actually get to no scars. No pain, no pain. This is something we're not where we need to be yet. And it's unfortunate, because there's this delicate balance between, I want to provide pain relief for my patient, but also not so much that they can't do physical therapy or eat or be able to socialize and that kind of thing. And so you walk really this thin line of individualized patient care, where you want to deliver enough pain medicine to help through their background pain or their procedural pain, but not so much that they're completely incapacitated, right? Because if they're bedridden for weeks on end, they're a heck of a lot more likely to die than if we get this patient up out of bed and start to move and start to be a kid again. So we're not where we need to be, but that's up to us to continue advocating for our patient and to see if maybe there's a better way than a one-size-fits-all approach, certainly. And then no deaths. This is something we're not at, not even close. And that's really unfortunate. We've gotten a lot better. 97% of major burn injuries will survive. However, 3% don't. By and large, out in the field, burn victims are dying from inhalation injury. It's the #1 cause of death out in the field from burn. In the hospital environment, it's infection. And I'm sure some of us know that all too well, even in just our early days at Shriners. But this is a very noble goal that Dr. Wolf has set us down a path on. And it's going to take all of us to make that happen. So we have to know, as a nurse, our role advocating for our patients, individualized patient care, but also thinking outside the box. How can we continue to evolve as clinicians, as burn care providers? So what factors most profoundly impact burn outcomes? Well, there's 3 major risk factors. One is a burn size greater than 40% total body surface area, okay? Less than that, you just don't have that systemic response that you would have like you would with a major burn injury, okay? Now with kids especially, even burns over 20% would be considered significant. If you think about like body surface area, they just don't have as much. Also, patient age greater than 60. So Dr. Wolf's calling himself old. He's not old. However, people who are older don't heal as well as kids do especially. And so patients over 60, even an insignificant burn is a significant problem, mainly because they have underlying comorbidities, things like cardiac issues, so fluids are going to be an issue, kidney issues, same thing. And then the presence of inhalation injury to the lungs. So if you inhale smoke during a fire event, then you're more likely to have a problem. And actually, all of these things compounded together, you can predict burn mortality. So there's something called the BAUX score. It's spelled B-A-U-X, which I know doesn't spell like it sounds. But what you do is you'll add these components together and get a score out of 140 that will help you determine burn mortality. So if you take this burn size greater than 40%, every point it matches to 1% TBSA. Okay, so if we use this example, 40%, 40 points. Patient age greater than 60. So here, 1 point equals 1 year. If we use this example, it would be 60, right? We're already at 100, which, not looking good. And then the presence of inhalation injury to the lungs, that's 17 points. Okay, and it's just flat, whether you have an extreme inhalation injury or just a little bit. You get one size fits all. So, adding all that together, we have 117 out of 140 chance of mortality, whereas 140 over 140 would be, basically certain death. Now, even if we have a case where it's 140 out of 140 or greater, we're still going to pull out all the stops for these patients, right? Like, we're not going to just let them die. Especially in the pediatric population, you'll find that people that you might have written off or there's no way they're going to make it through this, they do, which is absolutely incredible to witness. You could write a book about some of the children that we've taken care of. But this can be a good predictor of mortality. And just how serious this condition is. Especially you have an 80-year-old who had a 30% burn. You might think, oh, well, it's only a 30% burn, no big deal. But because of that age component, it really does make it an extreme complication. Another major challenge in burn injury is that damage to the skin sets the stage for bacterial invasion. And unfortunately, it's not just bacteria now. It's viruses that are opportunistic. It can be fungal infections. But unfortunately, that skin barrier that we have that protects us, it's not just sweat, it's not just something we got to keep clean or whatever. It is also your protection against microorganisms invading underneath what lies. So it can get into your bloodstream this way. It can have a direct channel to your heart. So unfortunately with burn injury, after inhalation injury, infection then becomes our biggest issue and biggest contributor to mortality. Also, you see imbalances in fluid homeostasis. This is due to a couple things. One is microvascular heat damage. So if you think about your capillaries, what they go through if they have this thermal event, they're just not going to be as good anymore. And for all of you who tried to thread that vein over burned tissue, you know exactly what I'm talking about, because it just doesn't work, right? It's because those vessels have been damaged. Now they can heal over time, but right after that acute burn injury, they aren't going to be working very great. Also, meanwhile, your body releases all these inflammatory markers, right? So catecholamines, boom, fly out. And that causes your capillaries to become more porous, and they're actually going to leak. So it's kind of this twofold issue. Capillaries are leaking fluid. The fluid that you don't have much of anyway, right? Like, through this thermal event, your body's going to kind of go into this hypovolemic shock. And that's why we have to do the 2 large bore IVs or a central line or an IO in order to give massive amounts of fluid at a designated rate, monitoring the patient's urine output, so that you can offset this imbalance in fluid homeostasis. So essentially, these patients are going into like a hypovolemic shock due to the leakage at the capillary. We can balance that out by giving fluids to help supplement that loss. Now, there's also a consequence that your patients will get extremely edematous. That usually subsides in about 48 hours, but there's definitely a push and pull with fluids that, again, many of you have already experienced. Thermoregulation. This is another extremely important concept, probably one that's actually lost most frequently in initial burn care. So thermoregulation is extremely critical, really kind of a twofold thing. One is your skin helps to act as an insulator. We sweat when we're hot and that kind of thing. Well, you've taken that out of the equation, so you have this additional exposure, right, where a cool breeze can really cool that core body temperature. Well, also, the body's going into a hypermetabolic response, and we'll talk a lot more about that through this course. And it's working in overdrive to heal itself. In addition, now it's having to work even harder to keep itself warm, which can cause a cascade of events that are detrimental to your patient's outcomes. So it's so important that, especially in the initial stages of an acute burn, that we are keeping those patients warm. It's extremely critical that you do that. There's a saying that we have in the burn world: cold and dry, they die. Okay? So if nothing else, with our ER providers, we are really driving that. Keep your patients warm. That means you don't expose them except when you need to. You don't use wet dressings because they're cold, and that cold will only serve to keep that person's cooler. We want to make sure if they're traveling by ambulance that the heat's turned up. If it's a cold winter night, we're minimizing that time out on the helipad and that kind of thing. And then when they're admitted to ICU, that's why we keep their rooms hot, right? Because they can't maintain their own body temperature. And unfortunately, this hypermetabolic effect will last sometimes for months on end, which is why many of our patients, we will keep those rooms really hot. So it is a major challenge in burn injury just because of the systemic issues that the patient has going on. And again, that hypermetabolic piece. So essentially, metabolism. Normally you would think, oh, okay, like my metabolism's slow. Man, I sure put on some weight this Christmas and that kind of thing. Well, metabolism is a set of processes. So it's not just like how fast you digest food, but more it's how your body produces and uses energy. So in a burn patient, for example, what you'll see is a lot of times that these patients' bodies are going into overdrive, essentially. About 20 to 30%, just kind of depending on the kid and the level of the injury. But their heart rates will increase, which is why you see tachycardia. They're going to breathe a little bit faster. They're going to be a little more anxious. And a lot of their underlying processes, including things like how they process nutrients, are going to be at this higher level, right? And it makes sense because the body's working overdrive trying to heal itself through this traumatic event. However, in that process, you have things like tachycardia, which can be problematic, sustained for a long term. So we do a lot to help suppress or to maintain that metabolic level because it is ramped up so much, and at some point, we give out. And we don't want that to happen. So there's a lot that we can do, more than I'm going to break down in this presentation. All right, a little bit about Shriners Hospital mission and vision. So this is what connects us all, whether you're a bedside nurse or the administrator or the maintenance guy. We're all here to provide the highest quality care to children within a compassionate, family-centered, collaborative care environment. We want to provide for the education of physicians and other healthcare professionals, such as everyone watching today, and the nurses that are in the room. And we also want to conduct research discovering new knowledge, improving the quality of care and quality of life of children and their families. We want to become the best at transforming children's lives by providing exceptional health care through innovative research in a patient and family-centered environment. And we're able to do that through incredible leadership with Dr. Stephen Wolf, and then with our other leadership, including our administrator, Mary Jaco, and our director of patient care services, Jeannie Keith. And most importantly, we carry out this mission without regard to race, color, creed, sex, disability, national origin, or ability of a patient or family to pay. Shriners is truly a nonprofit charitable institution. We are here to help children that have suffered burn injury. There's some other skin conditions that we treat as well. However, that's the bulk of our patient population. Our big thing is this is a service to humanity, and we want to give back. And we're able to do it through the Shriners, through wonderful donors, grants, and just really this incredible mission. So the next chapter, we're going to see a lot. It's kind of nice over here because it's quiet compared to being at Shriners. We're undergoing an incredible amount of construction right now as our Houston Shriners Hospital is moving in, allowing us to expand the services that we offer here in Galveston. It's going to be this incredible opportunity to serve more patients. We'll have even more reach, not just here in Galveston, but throughout Southeast Texas. And we're able to do that, again, through the leadership of Dr. Stephen Wolf and the incredible work of the Shriners and what they're doing to set the stage for our next generation. So why do we do it? Well, we do it for these kids, right? It's about that kid at the bedside. We drop our own egos so that we can deliver care through this mission. And it's a tough experience. Yes, it's tough for us and what we experience, but imagine what that kid goes through. But not only is it a tough experience, but there's so much personal growth that we get to witness, and that's what makes it special. It's not they're better and discharged. It's no, we got to give them life again, and then watch them return into their communities and help support that process. On the left, we have a couple of our patients that were working out in our wellness center, and you can see big smiles. It's a lot of fun, and let me tell you, it's these moments when you start to realize, I'm going to be okay, right? They're in there, they're doing something normal, and doing it with a friend. It's much better than walking alone, certainly. And here on the right, you'll see this is a picture of some individuals out on the beach and playing soccer. And let me tell you, these normalizing activities can be worth just as much as the medicine that we provide at the bedside. I mean, you'll have a kid who we thought was upset, and he came up and said he's crying. And we're like, what's wrong? And he says, I feel normal again, just from kicking a soccer ball around with his new friends. So don't forget that these are kids, and what they've experienced, sometimes just that sense of normalcy can be really what they need to start feeling normal again, and then to start working towards going back to their communities. And then I have to share this shot. At the age of 15, a young Hispanic woman has a coming of age through her quinceañera ceremony. It's a very big deal to a young Hispanic woman. And unfortunately, this young lady had to spend hers with us. But of course, we won't let any good party go unnoticed. And so we were able to celebrate while she was here, continuing to receive treatment, but also to recognize how important that was for her nurturing and growth as a young woman. And lastly, I want to leave you with this slide. So we have this incredible opportunity to treat these patients, to advocate for them, to collaborate with the entire healthcare team. But sometimes it's actually other burn survivors that they experience the most benefit from. And I think it's because they have that shared experience, right? And so you'll have someone that was burned 2 or 3 years ago and that's gone through life as a burn survivor and life after burn injury. And you have somebody who was just burned, a couple of months ago, and they're doing okay, but they're struggling with things like, what's going back to school look like? What's going to church going to be like? How do I go to the store? And so you have this mentorship relationship, and we have to also be very conscious of that and nurture it where we can. This is a picture we took at Camp Janus. It's a camp for burn survivors age 5 to 18. And it's a place, much like our child life department, where kids can just be kids again. And this is where that magic happens, where they really support each other and continue to grow as they navigate, life after burn injury. All right, so that was, again, our welcome slide kind of sets the stage for the rest of our presentations. All right, hospital history, conditions treated. So, as we mentioned earlier, burn injuries, they're still an issue, right? We haven't solved death. We haven't solved scars. We haven't solved pain, but we're getting there. They continue to be a leading cause of unintentional death in the United States. We see one civilian fire injury every minute, which is unfortunate, really. Most burn injuries that are treated in burn centers occur in the home, followed by work. And you'll see 73% are at home. What does that mean? It means it's not at school, it's not at daycare, it's not at church. So our efforts in burn prevention then might be best suited for how to prevent burns in the home, right? So it's important that we look at these demographics. Work, 8%, you think OSHA, that kind of thing. The odds of a U.S. resident dying from exposure to fire, flames, or smoke are 1 in about 1,500, okay? Which is unfortunate. Again, we don't want to see anybody die. By and large, you're seeing people getting burned at home. Very rarely do you see it anywhere else. 9% occupational. Other counts for 8%. But sports or in the street doesn't really account for many. By and large, we're seeing fire or flame burns as your number one cause, followed by scald shortly thereafter. Contact and electrical, not quite as common, especially electrical. Here in the United States, infrastructure is a little bit better. We see an international patient population, which may be why we've seen a higher incidence of electrical injuries. But normally out, in public, they just aren't happening that often. A lot better safeguards. Now this is an interesting disparity. Burn victims, by and large, are male. Anybody want to take a guess as to why men are getting burned more often than women? It has to do with frontal lobe development. Anybody want to take that? Come on, this is a fun one.
Doesn't it take longer for the frontal lobe and then to be developed?
Yes, that's absolutely right. And unfortunately, I don't know what it is, but little boys and fire often go together more often than little girls. But yeah, you see 2/3 male versus 1/3 female. I don't know if it's actually because of the frontal lobe development, but more risk-taking behavior for sure, which I think there's more of a correlation there. And mean age, 32 years old. So unfortunately, it does happen. Glad to see it's not as common in kids, but you will see a lot of scald injury in kids especially is kind of the big thing with tub water and that kind of thing. We see about 500,000 burn injuries that receive medical treatment. Could be small, could be large. Not always treated in a burn center. Go to the ER, pat your hand, that kind of thing. We see 3,300 deaths annually from fire, burn, or smoke inhalation. Hospitalizations are 40,000 a year, with 30,000 at burn centers, and it's actually the 5th leading cause of accidental death in children. Okay, so that's unfortunately what we see. We're partners with Blocker Burn, but they're treating more like industrial accident, adult house fire, whereas we see pediatrics in that wide scope. A lot of scald, some contact, some flame. Just kind of depends on the scenario. About 1/4 of all burn injuries are children under the age of 15. So again, that's our focus. And thankfully, 97% of those treated in burn centers will survive, though many of those survivors sustain serious scarring and lifelong physical disabilities. So again, not just to save someone's life, but we want to help prevent those comorbidities as well. All right, Shriners. Yay, it's a place we all know and love. It all started due to the Texas City disaster in November of 1947. And I know you guys got this little bit already, but I'm going to just retread real quick. So November 1947, there was a ship carrying ammonium nitrate, and it exploded, causing a series of other explosions at the Texas City port for really petrochemical industrial. Ammonium nitrate's a fertilizer. And so this explosion happened, hundreds of people died, thousands were injured, many of which ended up transported to the University of Texas Medical Branch for triage of this mass casualty incident. There was a gentleman named Dr. Truman Blocker who led this triage, and Dr. Blocker learned many lessons through this process, saved countless lives, and those lessons really set the stage for modern burn care, especially around things like how we manage fluids and fluid resuscitation, and then also the importance of excision and grafting. We're going to start a burn center in the 60s, and wanted to do it basically where modern burn care was, which is here in Galveston, Texas. So a pretty cool story, just a little bit about our history and how we came to be. And again, Dr. Truman Blocker, he was an Army surgeon, and it was through his work that we really were able to define modern burn care. The Shriners. So Shriners are a fraternity. They actually are initially Freemasons who become Master Masons, and then they have the opportunity to go different directions depending on what their specialty is in life, or what part they want to get back to. The Shriners specifically dedicated their time and their resources to this mission, right? To Shriners Hospitals for Children. That was going to be their service to humanity, to the world. And so they have, for over 100 years, been dedicated to the treatment of not just burn injury, but also orthopedics. And it's funny because, you look, especially a picture like this, these are guys in funny hats and driving little Model Ts, or I think they look like Jeeps. So how can these guys who are kind of funny and do parades do so much for, this incredibly vulnerable patient population? Well, they came together, and instead of continuing to support various philanthropies, they decided that they wanted to do their own. And so they collectively came together, and they put their money together, and they created this system, which is sustained because of their generosity, but also because of the expertise that they have brought in to help us take on this challenge of burn injury. So really cool group of guys that are able to help us navigate this. Again, they supported various philanthropies, decided to start their own about 100 years ago. The first Shriners Hospital was in Shreveport, Louisiana in 1922. As I mentioned, orthopedics was their initial patient population. And one of the public health crises that they were going after was polio, which was rampant at the time. Remember the iron lung and that kind of thing, what we remember from our textbooks. And so once the polio vaccine came about, they converted those hospitals to more exclusive orthopedics, so spinal cord injury, cleft lip, cleft palate, scoliosis, amongst other things. And then that's kind of how burns came about. So polio, that crisis was resolved, we hope. And now burns could be a crisis in which the Shriners could answer. And so while we maintained the orthopedic hospitals, now we found this new mission, or subset of our mission, to continue. Now we have 22 hospitals, 20 are in the United States, there's one in Mexico City, and then we have one in Montreal, Canada, offering specialized care to children with burns, orthopedic conditions, spinal cord injuries, cleft lip, and cleft palate. Again, burns, we wanted to be here in Galveston, and it wasn't enough just to come and we start and we meet the status quo. Again, we have been, on this trail of excellence ever since we started. And we reinforce our commitment to research and improvements in burn care through affiliations with the outstanding medical schools and nursing schools, including the University of Texas Medical Branch in Galveston. We've seen kids from over 43 states and 49 foreign countries. And more physicians have received burn care training at Shriners Hospitals for Children-Galveston than anywhere else in the world through research, residency, and fellowship programs. So let me tell you, and of course you guys know this already, if you want to learn about burns, you're at the right place. This is the place to learn about pediatric burn care. We're able to do it through wonderful people. The Shriners are wonderful donors. We have an endowment fund, all the charity events that hopefully we'll be doing again soon, but we'll see how that goes. And then we do this so that there's never a charge to our patients or their families for the health care that they receive. Our vision is to become the best at transforming children's lives, providing exceptional health care through innovative research in a patient and family-centered environment. So it doesn't matter who you are, where you come from, we're here for you. It doesn't matter if you're the bedside clinician or the manager or the maintenance guy. You know, we are all driven to ensure that these patients have high quality care delivered in a safe manner. So what do we treat? This young lady will be able to tell you. We treat burn injuries. So that's probably a majority of what we treat. There are some other things. You know, people think, oh, Shriners burns. It's about 95% of what we use or what we do, but not all of it what we do. And then we see burns in all stages. So it could be a little 1% touch stovetop kind of thing, or all the way up to 100%. You know, your entire body was engulfed in flames and that kind of thing. And we do save those children, which is you know, nothing short of a miracle. But what we see everything, we have an ICU, we have an outpatient, obviously surgery for acute injuries, for you know, day surgery or outpatient cases. We have telemedicine, so quite a bit of services around this burn injury, and try to meet the patients where they are. Hypertrophic burn scar. So unfortunately, burns leave a calling card in scarring. And there's a lot of things that we can do to treat the scar. So patients, even if they were never with us in the acute burn phase, they can come and have some revision to their scar, generally through laser, but sometimes some other surgical management as well. You can see the results are dramatic. So this is what Dr. Wolf is talking about, moving towards no scars. And we'd love to see this in a wider scale or with even better results. So we're continuing to push the envelope on what that can be. Ear microtia. So this is funny, but ear microtia actually has nothing to do with a burn injury. So microtia is a absent or underdeveloped outer ear. And that can be a congenital defect, right? So they were born this way, but our surgeons, who are so nice, have decided that, you know what, we can do this case. And so they use rib cartilage in order to rebuild the ear. It's a staged surgery. But you know, it kind of makes sense because a lot of our patients have ear injuries, many times with the outer ear being completely destroyed by their injuries. And so we can rebuild their ears, and why not take that skill set and then help out some other children who have a similar condition but caused by a different means. You made it. Port wine stains and hemangiomas. So port wine stains are essentially this consolidation of a vascular lesion, and a lot of times you'll see people have it. It's like a large birthmark on their face and that kind of thing. I remember a friend of mine's dad had one, and I always thought it was really cool and just different. You know, it's kind of this unique thing, and it never bothered him. But it does bother a lot of people, and our kids included, right? And imagine being that parent, you know, and your child having this, and you want, you know, something better for them. So we can treat that to reduce the discoloration, that kind of thing. And they can come in all sorts of shapes and sizes. Now, hemangioma is also a consolidation of vascular, and a lot of times these are so vascular that you know, you kind of just barely touch up against it and it bleeds profusely. So we can go in and we can reduce that or eliminate it completely. These are both treated using laser therapy. For a full list of our services that we offer, we do surgical excision and grafting. So that's a really important component of burn care treatment. Basically, we want to get the dead tissue off. If dead tissue harbors infection and you leave it on, all you're going to do is create this nice breeding ground, and that sepsis, or that invasion of bacteria, won't only be in the wound. Over time, you'll see it drift into the bloodstream and then throughout the body. So it can be very dangerous if we avoid that. Modern burn care techniques is basically early excision and grafting. So we want to get these patients in as soon as possible, get them to the OR so we can get that dead tissue off. Reconstructive and plastic surgery. So even in your acute burn phase, this is important. I want to know that my patient is going to have as much function moving forward as possible. And so even though, yes, we want to get the dead tissue off, we're still concerned with things like, okay, we did all this grafting on the hand. Well, I want to make sure I position them appropriately so that they'll be able to grab over time. Otherwise, those contractures can become so great that now, my patient can't use their fingers. So while we are definitely concerned in the acute phase with long-term outcomes and how people are going to look, we're also concerned with how function plays into it all. Now, burns, unfortunately, are also a lifelong condition for a lot of patients. And so what you'll see is that patients 6 months later, 1 year later, 5 years later, are going to have these issues that came up from their burn injury. Like Dr. Wolf mentioned, these kids are continuing to grow, and that can make it more complicated. So for example, I have a burn over my elbow. Well, over time, that scar is going to be very stiff, and I won't be able to do full extension at the elbow anymore, right? Well, with kids, it's this twofold problem, because not only do they have this scar, but meanwhile, their bodies are still growing, right? So their long bones are beginning to pull, and so you'll have these almost extreme deformities if no treatment interventions are put into place. Now, that's why it's so important as a bedside RN in the ICU that we're positioning our patients. What you do in the early days has a profound impact on long-term how they turn out. But also, some of it's unavoidable. Let me tell you, axillary contractures, good luck. Do all the positioning. Please don't, forget that or neglect it. But that is the highest area of skin contracture, is at the axilla. And so you'll see that more often than anywhere else. In cases like that, yes, we'll do the positioning, but over time, they're going to have burn scar release in order to maintain that function. So a lot of what reconstructive and plastic surgery doing, not just the aesthetics, how people look, but also how they function. Very important. Wound care, this one's kind of obvious. We got to keep the wounds clean even after the excision, debridement, and grafting. These patients don't have, normal skin layer, and so now they're at a much higher propensity for this infection. And unfortunately, it's the #1 cause of death in our patients, big burn injuries that make it past inhalation injury. Psychological support. So this is a tough experience for children, for their families, for caregivers too. We definitely suffer like a secondary traumatization from some of our patients. So it's really important that they have this psychological support in order to feel just connected with the world, life after burn injury. How do you navigate certain things? Psychology can help really with a lot of things. Could be a sense of loss from like your old self. Could be actual loss, like the house burned down, lost a family member. So psychology really an essential part of the team to help support the patient and their family through this process. Rehab therapy, obviously very important too. One of our presentations, I think tomorrow, is going to be rehabilitation. Rehab comes in the room for 1 hour in your entire shift, your patient's entire day. They're there 1 hour, and you are there 23. Well, 12-hour shifts, but we have nursing coverage for 24 hours. And so it's important in those other 23 hours, not that the nurse does a full, PT 1 hour exercise plan, throughout the whole day, but that we position our patients appropriately. Maybe before we, lay down for bed, we do a couple laps around the unit, that kind of thing. Because let me tell you, getting these patients up out of bed, it's that like normalizing activity. It's really tough, especially in the beginning, but you want to get them out of the hospital sooner than later. That almost more than anything is one of the biggest drivers, is promoting that independence. And it's I think especially important because they start feeling like kids again, like that sense of normalcy, like, oh, I can walk even with these extensive burns to my legs. Nutritional support, so nutrition, obviously very, very important component. Their little bodies are working really, really hard to heal themselves. And through extensive nutrition support, we're able to help support that process by giving proteins and fats to help rebuild bodies. But then also that hypermetabolic effect, since it's working overdrive, it can actually ease down a little bit since we're meeting the nutritional need of the patient. Pain management, it's really pain and anxiety. Anxiety is a bigger issue with children than with adults. Obviously a very, very important part of what we do. As I mentioned, individualized treatment plans are the best, especially when it comes to things like procedural sedation. But we're essentially trying to balance giving enough pain medicine to help someone through this whole process, so be it background pain or procedural pain, but then not so much that they're incapacitated to the point of not being able to do their treatments or eat and that kind of thing. Care management. So care management are wonderful. We have Rebecca joining us today. They are essentially the employees, the team members that are tying everything together for the patient. Their job here is especially complex at Shriners because we see an international patient population. And so how do you bridge the gap in getting someone here, receiving care, getting home safely? Oh, by the way, there's all these government restrictions with things like visas. Okay, how do you continue your service back home? Well, here in the United States, like, boom, there's this resource and that resource. But if you live in Panama, like, what does post-pediatric burn care look like? And so we can help make those connections and find members in those communities that can help support these patients. So again, that we can get them back not just as a burn survivor, but someone that can actually thrive and be full functioning members within their community. They do so much more. Under that umbrella is housing and transportation, is our medical translation, just an absolute array. And again, especially with that international consideration, the scope of that position is quite large, which Rebecca could attest to. And then child life and music therapy, probably one of the most important positions considering the pediatric population. Child life can help with procedural support alongside with our psychology team, whether it be a rehab therapy intervention or in the treatment room. They can help also with things like procedural preparation. So things like putting an IV. You have a doll, and hey, what does it look like to you? And they make the stabbing motion, and you're like, well, let's go back a little bit and actually talk through what that process actually is. Well, it depends on the nurse, but anyway. Music therapy is not the same as child life. They have similar end goals, just like our goals are all very similar. But music therapy is a way in which you can use music to help guide through a procedure. And it's kind of dangerous because you think, okay, your favorite artist is the Beatles. So I'm going to play the Beatles for you 24/7 while you're getting scrubbed in the treatment room and all that stuff, right? Well, what's going to happen is they were their favorite artist, and now they hate them because it's associated with like these terrible experiences. So don't feel like, oh, there's a CD, I'm just going to push play and let's go. Like there's almost this like prescription to the type of music and sound and ambiance that you create for your patients. Mary Kate, who's our music therapist, she'll talk a little bit about her specialty and then how you can help tomorrow in the child life presentation. So clinical care, this is what we do, right? This is the core of everything. On our second floor, it's home to our ICU, our surgical services team, and our treatment rooms. And this is where a lot of the magic happens. This is where patients get better. We don't have an ER, thankfully. There's just not that many burns happening. But we'll get a call, and maybe an ambulance service has a patient, maybe they're in an ER somewhere, and hey, we're going to bring them in. And we direct admit to our ICU, okay? And then patients stay there anywhere from, there's kind of this formula, it doesn't always work, but it's about 1 day per percent burn in the ICU. So if they had a 40% burn, you could expect them to stay at least 40 days. Now that would be with no complications, right? So if you had an 80% burn, oh yeah, just 80 days, right? But at 80%, they're at a higher propensity to have complications, so you would predict then that they would stay longer. Depending on the patient, we can get them out in as soon as 0.5 days per percent burn. But I mean, think about it. If we had a 20% burn and they got out in 10 days, like that'd be pretty impressive. But it can happen. You just have to have minimal complications. And it's not just the medical side. It's like, okay, is the caregiver up to speed on doing dressing changes and walking with the patient? Are they doing everything that they can? So it's not just like, oh, we've got everything covered on the medical side, but what about the family support? Is that there too? So that's really how we can be good models during our clinical care. Morning rounds. So we all know and love our morning round system. So 7 o'clock most days except for Thursday. They round at, Wednesday is 6:30. Rounds is such an important part of what we do. It's a touch point. And so we have this multidisciplinary approach where we can meet and talk about every single ICU level patient every single day, including weekends. It's also a benefit because they use this television screen. Now, in most places that wouldn't be ideal, right? Go see your patient. And of course, I think things have changed a little bit just in the last few months. But the video screen in burns is important for 2 reasons. One, you don't have 20 or 30 people going into your patient's room every single day, opening up those dressings and looking and seeing, what's going on. It's going to be an incredible amount of pain and discomfort. You're waking up the patient unnecessarily, right? But, and I would argue even more importantly, 20 or 30 people going into the room, that risk for infection now, right? Like we're exposing the patient so that we can see the wounds, right? Which are, you basically get the patient trauma naked to see everything. Now, you don't have that risk for infection because instead of everyone going in and out of the room, we're displaying everything on that TV screen. It also allows for the family to be an active participant in rounds as well. So they come out to the door of the patient while the providers are talking about the case. The close is, hey, mom, dad, what do you think? Do you have any questions for the team? And so we can address that, every morning in a group environment. We do afternoon rounds as well, but generally they don't involve the television screen. So it's more of a, notes, how are things? Have we achieved the plan for the day? What's tomorrow look like, etc. Family-centered care, very important part. You heard it in our mission. We are an international facility. Part of that consideration is people need to stay somewhere. And my goodness, spring break and summertime in Galveston, it's hard to find rooms. So we have some in-house. There are 4 in-hospital family rooms, 16 family units adjacent to our hospital. That's in our back parking lot. And then 5 multifamily units a few blocks away, Mediterranean. Ronald McDonald House, local hotels, which should be the last resort. Unfortunately, lately we've been using a lot of hotels. And then daily local transport, so just getting people around. So we want to bring people in, keep them close. We don't just take your child, we take the child and the caregiver. And you got to have a place for mom to stay. So this is how we do it. That's going to be changing through our transition. So more to come. This slide will be completely different. Life after burn injury, like I mentioned, normalizing activity is so important. Encourage as much of that as you can on the unit. If you're kicking the soccer ball around, just make sure they don't fall, right? But little things go a long way. Just remember these are kids underneath the burn injury, so see past the injury. It's a kid, right? Phoenix Society for Burn Survivors is available. It's a resource not just for burn survivors, but also for providers like us. STEPS is essentially a program in which we can ease up into returning to a public life, without fear for staring and bullying and that kind of thing. Burn camps, I talked about Camp Janus. That's a regional burn camp. There's some that are more throughout the state, but then also some available nationally. And that's a way for this burn survivor community to come together and really just have fun. Like, if you've ever been in our child life playroom, you know it's a sanctuary within our hospital, right? Like, we can't go in and put an IV in, can't even wear a white coat. Well, imagine being at a place that's built for, you know, kids that have adaptive needs. And they can go and do things that they never thought were possible. Like, how do you climb a rock wall with no arms or legs? And they're like, well, we're going to show you. It's pretty cool. School reentry programs, talked about that one as well. So essentially working with the faculty and the student body to bring Johnny back and to ensure Johnny has the best outcomes in school ever. And so this is a really important part in that reintegration process. We have a tissue bank. We process donors here. So if you ever donate your skin, it could potentially end up at Shriners. You've given a lot of your time, now give us your skin. So all that being said, we're able to process and basically create homograft, which is skin from a cadaver, here in our own tissue bank. And so we store it whenever it's ready to go, then we will apply it to the patient. We also do some other skin and skin substitutes, so things like xenograft, which comes from a pig. Autograft is actually from the patient themselves. And generally we don't bank, so if we take some, we'll use that during surgery. Telehealth, this is a way to reach patients and providers all over the world. Since our patients are international, maybe it'll be easier to connect with them through telehealth than it would be to get them here. And especially lately, this has become more and more common. Transportation course, so this is a really fun one, and you'll see Marty in the picture, so Marty is our next speaker. Transport course is an annual course. We're actually not holding one this year, unfortunately, but an annual course where we bring our flight teams in to join us for training. And so we'll bring the latest standards and techniques. We'll have a skills lab in addition to a lecture format where, yeah, we really get to showcase the latest and the greatest in medical transport care. So this is something that's available to all staff. As I mentioned, we're not doing it this year, I think for obvious reasons, but this is something we definitely want you guys to participate in when it's available. So Shriners does answer the call. Sometimes there are international events in which we respond. The most recent being the Guatemalan volcano. Volcano explodes, hundreds of people died within hours. It was just a very fast-moving, super hot ash cloud. And there were many kids that were affected by this injury, 6 of which that actually got treated at Shriners Hospitals for Children. This big, Marty, what plane is that?
That's a C-130.
C-130, yes sir. So that's a big military transport aircraft that there was a joint venture. It was between the Army and the Air Force, and they did essentially a training mission, but with these patients from Guatemala to bring them over. And so we got to be cool, especially considering it was a joint effort between the military and civilians, i.e. us. Some programming for kids is out there. It's not just for kids, but for teachers, for nurses too. Like if we want to take things into our communities, things like burn prevention, or the example shown here is Cut the Bull. So Cut the Bull was a program, R.J. Mitt, for those who've seen Breaking Bad, anyway, he was a star on that show. And he helped us to support anti-bullying through this campaign. These are some of our Galveston's staff ambassadors, or I'm sorry, patient ambassadors, and they helped us promote Cut the Bull. It's a program that we bring to schools, a lot of times to supplement with some burn prevention education. So we'll do a talk on why you shouldn't bully, and bring some burn survivors. I mean, talk about a powerful message. And then to follow up, we'll teach some burn prevention techniques. And last but not least, our Chief of Staff, Dr. Stephen Wolf. It's through his passion and dedication to this mission that we are able to succeed. And so he's really setting the stage for our next generation of burn care. really advocates in ways, beyond much of what I even know about. But it's interesting seeing how he's putting things into place to see us, rise to the occasion and become even stronger, even in the midst of coronavirus, even in the midst of this transition that we're going through. It's through his dedication and leadership that we're going to be successful. With emergency referrals, please give us a call, our ICU. We're open 24/7. We're also able to help with things like management of burn injury if maybe you're 1,000 miles away. That number is 409-770-6773. All other referrals, so these would be your not acute, not life-threatening referrals. Maybe you need to go be seen in the outpatient environment. Call 1-888-215-3109. All right, any questions?